if they screen positive for overcrowding, which means having 3 or more people in a bedroom, multiple moves, which means having had to live in 3 or more places during the course of a year because you could not afford your rent or mortgage, or being doubled up, which is a polite way of saying that you actually don't have somewhere to live, and for example, you're sleeping on somebody else's couch. And then finally, energy insecurity is defined as being present if a family screens positive to any one of the 4 items listed there, having received a heat or electricity shutoff letter from a heat or electric company due to inability to pay, actually having had the heat or electricity shut off, having had days that their home was not heated or cooled because they could not pay, or having to use a cooking stove to heat their home. So with those definitions in hand, let me just move on a little bit to the context of poverty in pediatrics. I think many of you are probably familiar with these data, but it's worth highlighting anyway. Child poverty is incredibly common in the United States. 1 in 5 children in the United States comes from a family living below the federal poverty level. As I said, for a family of 4, that's just over $24,000 per year. It's commonly accepted now that 100% federal poverty level probably is not, in fact, enough to get by on a day-to-day basis, and instead 200% federal poverty level may be the minimum amount a family needs. And if you look at those numbers in the United States, then, oh, and my animation is not working here, that should have shaded in another child, then the numbers become 2 in 5 children living below 200% federal poverty level in the United States. What about those concrete measures of poverty that I mentioned? The federal government collects annual data on household food insecurity across the U.S., and those data are pretty consistent over the last 10 to 15 years, such that just under 20% of children in the United States are currently living in a food insecure household. Now, why are those data pertinent to pediatric cancer? Obviously, here I'm talking about pediatrics in general, and I'm going to argue 2 main reasons. One is that every child who comes to us with a diagnosis of cancer before that was a child without cancer. But the second is that we as oncologists need to be thinking about our families walking through the door and what they're looking like from a socioeconomic status, and recognizing that 1 in 5 children who we see with a new diagnosis of cancer is already coming to us from a family with significant financial hardship. What about the implications for child health? Again, this slide is focused on general pediatrics, and then I'm going to move specifically into the pediatric cancer space. The punchline here, you'll note, is that poverty is bad for child health. So we know that children living in high poverty areas have significantly higher all-cause mortality than those from low poverty areas. We know that low-income children are significantly more likely to be in fear of poor health, to experience developmental delays and learning disabilities, and to have chronic illnesses, for example, asthma. And we also know that children and families with household material hardship, for example, food insecurity, have higher rates of hospitalization, fair or poor health, injury, and infectious disease. What about poverty in pediatric cancer? What do we know? At the beginning of this, George mentioned that there's a lot left that we do not know, and that is true, and hopefully I'll highlight some newer data that we've gleaned about this. But there are a couple things that have been pretty well established at this point. You'll note that the first bullet point up here is not actually about poverty and pediatric oncology outcomes. It's instead saying that childhood cancer treatment is associated with significant financial burden for families. And this is highlighting what I mentioned at the very beginning, which is not only do 1 in 5 children come to us with a new diagnosis of cancer already living in poverty, but we are exceptionally good at making families impoverished during therapy. There's a large body of work now out of both the United States, Australia, Canada, demonstrating that treatment-related financial hardship is significant for families undergoing cancer therapy. Data pretty consistently show that about 1 in 4 families report losing more than 40% of their annual household income as a result of treatment-related work disruptions. So that's not even taking into account out-of-pocket expenses, for example, travel to the hospital, extra food, treats, childcare at home. We additionally know that other work disruptions, such as having to quit a job or change a job, are incredibly prevalent. Work out of Anne's group has demonstrated that this happens up to as frequently as in 1 in 3 families. And we also know that treatment-related income losses and out-of-pocket expenses can cause families who are initially non-poor to become poor during therapy. And the data that have been published suggest that this number is probably somewhere between 10 and 15% of U.S. families who are non-poor at the time of their child's diagnosis will become poor during therapy as a result of treatment-related financial burden. So with that as the first bullet point, it's also been demonstrated that family income poverty is associated with decreased adherence to oral chemotherapy in the clinical trial setting. This is work from the Children's Oncology Group, specifically Dr. Smita Bhatia, who has looked at children successfully taking all prescribed doses of their oral mercaptopurine, which is a oral chemotherapy agent used in ALL, the most common leukemia in childhood. And one factor which was shown to be associated with a higher risk of not taking all of your 6-MP was lower family income. It has also been demonstrated that area-level poverty and family income poverty at the population level are associated with decreased overall survival for children with leukemia. And I highlight at the population level because these published studies were not able to take into account the actual treatment that a child received or any of the biological risk factors of their disease. So with those data that I just presented, what are the research gaps that are worth addressing? I've highlighted 2 here that I've been focused on. I would argue that the potential impact of financial hardship on pediatric cancer outcomes really has not been systematically investigated as part of our clinical trial design. And this is a major shortcoming in the field of pediatric cancer because a large proportion of our families are treated on clinical trial, which means that we're gathering all sorts of biological data about their child's cancer and how that relates to outcome, but we have not to date been taking into account any of the social determinants of health, whether that's pre-existing poverty or financial hardship during therapy, which might impact outcome. To date, there has been no upfront systematic collection of measures of poverty or financial hardship in our clinical trial design. And when we have collected data, we've relied on what I would consider to be non-targetable measures of poverty, for example, area-based poverty. So I'm going to shift gears and move into recent work that was completed by my group and then finish up with current work that's ongoing. And so one of the first questions that I had in beginning my investigation of whether there is a relationship between poverty and childhood cancer outcomes was, do targetable measures of poverty exist in pediatric cancer? In other words, are those measures I mentioned, household material hardship, are they actually common enough in our patient population that they might be worth systematically studying in an upfront cancer setting and then thinking about intervening on? And so to answer this question, we did a pretty straightforward single-site survey study. The objective here was to determine the prevalence and trajectory of household material hardship as previously defined, so food, housing, or energy insecurity, in newly diagnosed pediatric cancer families. We did this study as a single-site study, and it was a prospective longitudinal cohort study. The method was a face-to-face survey, which was conducted at 2 time points. So parents of newly diagnosed children were asked to complete a survey within 30 days of their child's cancer diagnosis, and that was our baseline. And those questions let us understand what their family looked like prior to their child's cancer diagnosis. They then completed a follow-up 6 months into chemotherapy, and the purpose of that was to understand what their family looked like after undergoing some intensive treatment for 6 months and after having been well hooked into the medical system, including existing social supports. The instrument was a 120-item survey, which included some de novo items and a number of validated instruments. And the cohort for this study was 99 newly diagnosed pediatric cancer families who were treated at Dana-Farber. We had an excellent response rate of 87%. The cohort included English-speaking only families, which I will highlight as a limitation of this study. Their child had to have a primary diagnosis of any cancer, and they had to have planned receipt of chemotherapy at Dana-Farber so that they could complete the follow-up survey. And I will note here that this means that we excluded families of children who were only going to have surgical resection or only receive radiation therapy. On the next slide, you'll see a bar graph which is highlighting the primary result of this study, which was to understand the prevalence of material hardship in this patient cohort at baseline and at 6 months. In the blue bars are family reports at the time of diagnosis, so within 30 days of their child's diagnosis of cancer. And in the red bars are family reports 6 months into chemotherapy. And you'll see, looking at the far left, is any household material hardship. And at the time of diagnosis, our cohort looked a lot like the rest of the United States population. About 20% of our families told us that they had experienced food, housing, or energy insecurity in the 6 months prior to their child's diagnosis. By 6 months into chemotherapy, this number had increased to 30% of families reporting food, housing, and energy insecurity, and that was despite existing psychosocial supports, which in this clinical context included both a dedicated assigned psychosocial provider as well as having had a one-time consultation with a resource specialist, which means a social worker whose sole job was to address any concrete resource needs. On this slide, I highlight a secondary aim of this study, which was to try and understand what work disruptions and income losses looked like in this patient cohort, really with the idea of wanting to get at what might be driving rates of material hardship that we identified. And I think the major things to highlight here are that at 6 months, 1 in 4 of our families reported that they were experiencing annual income losses of over 40%, specifically due to treatment-related disruptions. This type of catastrophic income loss was significantly more likely to occur in low-income families, which we had defined as being less than 200% federal poverty level at the time of diagnosis. And then when we looked at our families who'd begun in the non-low-income category, in other words, at the time of diagnosis, they made more than 200% federal poverty level. 12% of our families had dropped below 200% federal poverty level as a result of these treatment-related work disruptions. I think the only additional thing to highlight on this slide, and I did not provide a table 1 for this study, my apologies, is that the patient cohort being treated at Dana-Farber was slightly more well off than if you look at U.S. median household income, meaning that these rates of income losses are probably less pronounced than one might see in a less socioeconomically secure cohort. So moving on, and I don't want to dwell too much on this, when we got those results showing us that 1 in 3 of our families 6 months into chemotherapy were experiencing food, housing, or energy insecurity, families in particular raised with us the question of, what did this look like later on in therapy? Was this something that was just an acute impact of treatment and it would get better, or was this something that was going to persist? And so we did a quick follow-up study utilizing that same cohort that I presented before, so those 99 families who had completed a baseline and 6-month follow-up survey. And for this, the reason it was a sub-cohort was that we chose to conduct a 3rd time point survey for families at least 1 year off therapy. And the purpose there was to try and understand whether things had gotten back to baseline or were getting worse or were staying about the same. Families for this were asked to complete a single follow-up survey. Again, it was administered either face-to-face or by telephone. And here we had 52 of the original 99 participants, and that was mostly due to our eligibility criteria. They had to have previously participated in the prior study. Their child had to be at least 1 year off therapy. We excluded families of children who had either relapsed or died of their disease. And we excluded the 6 families of children who had been lost to follow-up during the original study, and their primary team had to grant permission to approach. The one comment I'll make before showing the punchline data for this are that the 52 families in this sub-cohort did differ from the original 99 families in that they were significantly more likely to be college educated. They had higher baseline median household incomes of $108,000 at the time of their child's cancer diagnosis, and they were more likely to be Caucasian, in other words, non-racial or ethnic minorities. And the punchline from this study is straightforward. This is the same bar graph you saw before with the addition of the new black bar, which is identifying in this cohort their responses at least 1 year off therapy. And so, again, you'll note, as I mentioned before, this cohort was a little bit better off overall cohort. So at the time of diagnosis, only 15% of them reported household material hardship as compared to 20% in the overall cohort. But you'll see that the punchline here is that at 6 months, they also reported just over 30% having food, housing, or energy insecurity, and that percentage of families persisted at least 1 year off therapy, such that these families were still experiencing food, housing, or energy insecurity. I'm going to move on now to the next question in the interest of time, and that was, we felt that the data from that study suggested that, in fact, there is a targetable measure that is prevalent enough in our population that it's worth investigating further, but really wanted to get at the fundamental question of whether poverty impacts childhood cancer outcomes in the clinical trial setting. So to answer this question, we used a retrospective data set. Here the objective was to identify the relationship between community-level poverty and lymphoblastic leukemia, or ALL, disease outcomes for children who had been treated on multi-center clinical trials. The design for this was a retrospective data set analysis, and the data set that we used were data from 2 consecutive phase 3 multi-center trials for pediatric ALL that were conducted from 2000 to 2010. And these were protocols DFCI 00001 and 05001. And just as very brief background, the DFCI ALL Consortium runs consecutive clinical trials for children with ALL. These are conducted at 9 academic medical centers across the United States and Canada. And these trials have been being conducted as a consortium since the 1970s. These are run separately from the Children's Oncology Group studies. The cohort for this analysis included 575 children. They were aged 1 to 18 years. They had primary diagnosis of ALL. And for inclusion in this analysis, they had to have an available zip code. And the reason for that was that no socioeconomic data about households had been collected on any of these trials. And so what we did instead was to use zip code and link that to U.S. Census data, such that we were able to identify zip codes as either being high poverty zip codes or low poverty zip codes. And that's a U.S. Census definition, where a zip code is considered to be a high poverty zip code if more than 20% of households in that zip code live below the federal poverty level, and it's a low poverty zip code if fewer than 20% live below the federal poverty level. I have 2 slides of outcomes for this study. On this slide, you are looking at a Kaplan-Meier curve of survival. On the y-axis is the probability of overall survival, and on the x-axis is years from enrollment on trial, and we start at the time of remission and induction. In red are children who come from high poverty zip codes, where more than 20% of families live in poverty, and in black are children who come from low poverty zip codes. And our finding here was that 5-year overall survival differed between those 2 groups of children, such that children from high poverty areas experienced a lower overall survival than those from low poverty areas. After adjusting for NCI risk criteria, this became statistically non-significant with a p-value of 0.07. On the next slide here, you're looking at a cumulative incidence curve of relapse. Again, in red are children from high poverty areas, in black, children from low poverty areas. And the punchline here is that when we looked at the children who relapsed, you'll note that the curves overlap at the end. In other words, there was no difference in the absolute number of children from either group who experienced relapse. What was different was the timing with which so the red curve gets there faster. And what we found was that children from high poverty areas were significantly more likely to experience early relapse, which means having had a relapse of their leukemia less than 36 months in remission, than children from low poverty areas. And this is clinically pertinent because children who experience early relapse of their ALL are significantly harder for us to salvage with further chemotherapy. So the punchline that we took away from this study was that there was a signal that area-level poverty was associated with inferior outcomes for children treated on multi-center clinical trials at academic medical centers, but that we did not yet know whether household measures of poverty had that same association. And so that leads into my current project, which is ongoing at this point in time, and I'm just going to give a very brief introduction to it. The first 2 studies led me to be very interested in looking specifically at that targetable measure of poverty, household material hardship, and disease outcomes. And we, after looking at our data and really having some collaborative relationships with general pediatricians who've looked at this topic, have 2 central hypotheses that we think might mechanistically link material hardship and disease outcomes. And both of them have to do with successfully getting chemotherapy into kids' bodies, which is the way that we know how to cure them of their disease. The first is that children from families with household material hardship may experience decreased adherence to oral chemotherapy. And the second is that children from families with household material hardship may experience more dose modifications and delays in their chemotherapy. So when I say this, we know that kids who come from low-income homes have inferior underlying health status. And that's data from general pediatrics, whether you're looking at comorbidities, number of hospitalizations, infectious disease. The hypothesis here would be that if you're beginning your chemotherapy with more comorbidities or that you're less well overall, perhaps you might experience more toxicity of treatment, which in turn might make your oncologist have to dose reduce your chemotherapy or delay cycles. Similarly, there's a hypothesis that potentially children from low-income homes may have delayed access to care, leading to higher acuity admissions. And the example here would be if a child lives in a family, for example, without access to easy transportation, and they have a fever in the middle of the night and they're neutropenic and need to come into the emergency department for IV antibiotics, perhaps delays in getting to the emergency department might make them end up being sicker and, for example, being admitted to the intensive care unit than a child who has easy transportation access and is able to get those IV antibiotics in less than an hour. And so the study, and I am recognizing I probably have just a few minutes left to get through here, that we're currently doing, we're conducting a prospective inception cohort study embedded in a phase 3 multi-center therapeutic trial for pediatric ALL, and that parent trial is DFCI 16001. And so here my primary objective is to determine the prevalence and trajectory of household material hardship from the time of diagnosis throughout treatment, and then to assess the impact of HMH on disease outcomes, specifically early relapse and overall survival, aim 2, adherence to oral chemotherapy, specifically 6-mercaptopurine and dexamethasone, and then an exploratory aim of looking at the impact of HMH on care utilization, specifically emergency department visits and ICU utilization. This is an embedded study in an existing multi-center therapeutic trial for children with ALL, and to be included in this embedded study, the child has to be enrolled on the parent therapeutic trial, which is DFCI 16001, and they have to be aged 1 to less than 18 years. The instrument here, the baseline survey, is 37 items, and the follow-up is 26 items. And it's administered as a face-to-face parent survey at 4 time points. You'll see here a schematic for treatment at the bottom. The major takeaway is that the baseline survey is given during induction chemotherapy, so within the first 32 days after a child's diagnosis, to understand what that family looked like prior to diagnosis. And then there are follow-up surveys at approximately 6-month intervals throughout therapy, culminating in a final survey at the end of therapy. And here the idea is that while we are powered on the relationship between baseline material hardship and outcome, we are also interested in the concept of financial hardship during therapy and whether that in fact is associated with outcome. The timeline for this, the trial was activated in February 2017. We are actively enrolling. We've enrolled 6 children to date, thus far with a 100% consent rate to the optional embedded study, and we anticipate to accrue this between now and March 2021. And so my next steps, I'm going to wrap up my portion here in the next minute. While we are actively collecting data on the relationship between material hardship and disease outcome for children with ALL, we're beginning intervention development, with the idea being that our next step will be to embed an intervention targeting household material hardship in our next clinical trial with ALL. And I've put up here the 3 buckets that are part of our intervention development right now. Bucket number 1 being the concept of systematic screening. In other words, if we don't ask and we do not know that you're experiencing food insecurity, we certainly can't intervene on it. Bucket number 2 being systematic linkage, meaning that once we identify some type of material hardship, for example, food insecurity, families have to be systematically linked to existing resources. An example of that would be food stamps. And then bucket number 3 is the concept of novel partnership. And this is the fun part of the intervention development, thinking about ways that we can really bring new things to this field. And one likely component of this will be a partnership with Uber, which will allow us to offer available prepaid transportation to families without easy access to transportation, for example, in the middle of the night when their child has febrile neutropenia. So in summary, there's a major challenge in our field, which is that poverty and financial hardship are not currently addressed in a systematic fashion by pediatric oncology care delivery or investigation. I think at the same time, this is a really amazing opportunity for the field of pediatric oncology because these measures, poverty and financial hardship, across all histological subtypes, risk group stratifications. These are domains that are present for 1 in 5 of our families at the time of diagnosis, and more than that as they progress therapy. And what that means is that if we're able to come up with interventions which in fact may help this, we have the opportunity to potentially make huge improvements both in quality of life and potentially in disease outcome for our children and families. And with that, I'll just acknowledge my mentors and my funding source, specifically my K07 from the NCI right now, which is allowing our ongoing trial. Thank you so much.
Great. Thank you very much, Dr. Bona. Appreciate that. I have some questions myself, but I think in the interest of time, I'm going to pass this off to Anne and Elise, and I'll let them take it away from there.
Great. Thank you very, very much. This is nice. I'm honored to be sharing this panel with other colleagues and researchers who are doing this similar work. I think this presentation is a nice follow-up to Kira's presentation, and that what we're seeing is that the issues that begin in terms of financial hardship during treatment for pediatric cancers are unfortunately continuing. Dr. Kirchoff and I did a study starting a few years ago, and we're still analyzing the data and building off of that, taking a sample of childhood survivors, and fortunately we had sibling controls to really look at what are the health insurance concerns and coverage among these folks. This has been a pattern of research that we've been working on, I'd say, over for the past decade. And we've done a lot of qualitative and quantitative work really looking at the impact of inadequate health insurance coverage on childhood survivors. And our aim in this work was to really document what type of coverage they had, how this impacted their lives. So it wasn't just enough to look at our childhood cancer survivors covered, but what kind of coverage do they have? And that's what we really want to do an in-depth exploration of. First slide, please. So the overview, basically, we want to look at childhood survivors and whether they were familiar with the Affordable Care Act. We will show data that was collected a year after the rollout of the ACA, when most of the major provisions were enacted. We're going to be looking at talking about a survey itself that focused on questions related to the ACA, and then data looking specifically at financial burden at costs of care and insurance that has been done by 2 of our oncology fellows. And then we'll talk a little bit about follow-up and plans and potentially our hope for in terms of intervention work. So the background here, I'm preaching a bit to the choir, but we know that advances in treatment care have resulted in a growing population of adult survivors who need ongoing medical surveillance. The vast majority now of childhood cancer patients survive the past 5 years, over 80%, and this is a growing population, which is exciting in terms of survival rates, but it's also a growing opportunity in terms of ongoing care. Quality health insurance is critical for them. Survivors are at risk for being, we know, uninsured, which not having insurance even after the ACA passing, and underinsured. And underinsured is defined as spending more than things like 10% of your income on health care costs, or $2,000 out-of-pocket costs per care, or things like skipping needed medical appointments or not filling prescriptions. Those are all markers of underinsurance. And we know that uninsured survivors are at risk for not receiving recommended survivorship care, is that they actively choose to forego recommended care because of costs. So in 2010, the Affordable Care Act was established, and there were provisions that were really meant to increase access to vulnerable medical populations with pre-existing conditions like childhood survivors. So there were several provisions that would assist survivors. One is high-risk insurance pools that survivors could buy into. Coverage expansion to age 26. This is particularly important because we know childhood survivors tend to marry later and live with their parents longer. Medicaid expansion, which is also important because we know that survivors are disproportionately likely to be covered by Medicare. Regulations specifying essential health benefits, so preventive care and primary care visits being required. So survivors, we thought, might be at risk for unmet healthcare needs and financial burden, which we operationalized as costs showing up as costs and worries. And why? Because survivors, disproportionately, child survivors have low incomes and live in states that are not participating in the ACA's Medicaid expansion, so they're not eligible for those Medicaid benefits. They often forego coverage because of cost, and we know that from a lot of qualitative work that we've both done. They're narrow network plans, so their plans limit actually what type of care and specialty care, where they could get that care, or hurdles that they need to overcome to get that care. They're lower premium plans, so they which limit access at all to specialists, and they might not have coverage for survivor-specific prevention guidelines. This is important because the ACA mandates that the U.S. Preventive Task Force guideline recommendations are covered, but survivors of childhood cancers often have different prevention recommendations. So, for example, starting earlier mammography screenings before age 40 if they had chest radiation, and these survivor-specific recommendations for preventive care are unlikely to be covered. So in the U.S., many adults, we found overall, a study that was done a couple of years after the ACA was rolled out and published in 2014, many adults do not understand their insurance benefits and have limited health insurance literacy, and that's being able to feel confident about and understand some of the basics of their health insurance coverage. And we did not know the extent to which childhood survivors really understood the ACA or had their health insurance coverage preferences upheld. So what we know is that over 8 million uninsured survivors gained access after enactment of the ACA policies, so that which was positive, but we knew that about 1 in 10 in the U.S. population still remains uninsured. Some people ask us about this work because they feel that most people should have health insurance at this point. Well, even after the ACA, 10% don't. We don't know, though, how much of that has, how much childhood survivors themselves have gained health insurance coverage due to the ACA. That is still unknown. We know that survivors are at risk for, like the general population, higher financial burden of health insurance due to higher co-payments, deductibles, and declines. We know that employee-sponsored insurance is declining, so the likelihood of an insurer covering you for all individuals in the country is declining. And we thought that potential changes may affect health insurance coverage for survivors, but we don't know. So we conducted a survey. We published work. Anne had published some work about looking at SSI and comparing survivors and siblings. I had done this work looking at childhood survivors' knowledge of the Affordable Care Act, and we had done some preliminary work looking qualitatively, as I said, asking survivors about their knowledge and understanding and satisfaction with things like health insurance and their understanding of things like SSI. So the study, we interviewed survivors, and then we surveyed survivors and siblings. We assessed their coverage preferences, their coverage perceptions. Were they satisfied with their care? What were their care needs and difficulties obtaining care? How familiar were they with the ACA and other health insurance-related legislation? What did they want in a health insurance plan? And what are their experiences with federal disability coverage? So we asked all of these domains here that are represented in this, and we had on this little bubble here was how we asked the question about the Affordable Care Act, just in case folks didn't know as they are filling out the surveys. And the surveys, again, were filled out a year to a year and a half after the ACA was passed. In March 2010, the Affordable Care Act was signed into law. The following questions will ask you about your familiarity with and opinions on the law, as well as priorities and willingness to pay for future coverage. So we really framed it, we were very clear about the definition so that we knew that they knew what we were asking about and our intentions in the survey. We had survivors and siblings filled out the same survey. The first question would screen if they were insured or not, and then there were parallel surveys for folks who are insured or uninsured. And so this was our flow chart. We did a selected sampling from the overall childhood survivor study, which is a cohort of over 20,000 survivors and over 3,000 sibling controls. For this study, we couldn't survey all of them, so we did a random selection, and we ended up in the end analyzing data from 698 survivors and 210 siblings, and those are from 25 pediatric tertiary care centers around the United States. And so what we found with participants is this was a survey that was started in the late 90s. So these participants are fairly well established and older survivors. So we made sure that we got a representation of survivors under 30, but you can see about a third were in their 20s, a third in their 30s, and a third over their 40s. Half over in terms of survivors and siblings, a little under half were male. It was a fairly homogeneous sample with over 90% being white. Education was some mixed, but over half of survivors and siblings had completed college. And there we see the difference in the expected direction that survivors are less likely than siblings to be married, with half of survivors being married and 2/3 of siblings. And survivors and siblings, about 3/4 that were employed in some capacity at the time of the survey. So we looked at their history. A third had leukemia diagnosis, which is the most common form of childhood cancer. Half of the sample was before age 5 at the time of diagnosis. There's a mean of 30 years since diagnosis, and about just less than 20% had had a recurrence or second cancer. In terms of their coverage and concerns, what we saw was that survivors were less likely to have employee-sponsored coverage. They were not significantly less likely to be insured, although there was a difference in terms of the percent of survivors that were insured compared to siblings, but that was not significantly different. Survivors were more likely to be covered by Medicaid, which we expected. They were more likely to acknowledge that they had a history of the health insurance being denied, had difficulty in the past 2 years of getting coverage, and having greater percent of their income spent on medical expenses. And that last row is the indicator of being underinsured. When we asked them about the Affordable Care Act, their familiarity with the Affordable Care Act and other legislation, we looked at comparing survivors and siblings and survivors by insurance. And what we found was actually, if you look at the survivors by insurance, the uninsured survivors are significantly less likely to know about the ACA or any health insurance-related legislation. The American with Disabilities Act has been enacted in the 1990s to allow provisions from a disability, a discrimination. The FMLA, COBRA, HIPAA are all legislation meant to have some protective components to them. So it's significant that uninsured survivors are significantly less likely to know about these protections. When we look comparing survivors to siblings, we don't see actually very marked difference between familiarity and knowledge of these legislation. Although when you look, their familiarity overall with this legislation is pretty low, and fewer than about a quarter of survivors and siblings admitted to familiarity with the ACA, despite the fact that it had been rolled out for over a year when they filled out the survey.
Okay, I think
is Anne. Thank you, Anne.
Yeah, thank you, Elise. So I appreciate both the comments from Dr. Bona and Dr. Park on their results from looking at material hardship and insurance, because I think that sets up nicely the last sets of slides that I'd like to talk about related to cost of care and the medical cost burden for childhood cancer survivors. And then also I'll talk a little bit about the next steps that Dr. Park and our research team are planning, building off the results from this national survey that we've done. So just to start here, the background slide here. As we know, survivors of childhood cancer and adolescent and adult cancers often forego health care because of cost. And as Dr. Park talked about, we know that uninsured patients often have high out-of-pocket costs, which can really be kind of a marker of being underinsured or uninsured. And so this is often examined from an out-of-pocket cost standpoint as spending more than 10% of household income on healthcare costs. And so keep this in mind, because I'll present some results where we looked at this in our survey. However, little research has really dug into this question among long-term survivors of childhood cancer to understand their medical cost burden, what sort of out-of-pocket costs they have, and how do these expenses affect their use of health care. So the next few slides, I'm going to show results from some analyses that two of the oncology fellows with our team, Ryan Knipp and Doug Fair, have done to look at the medical cost burden among childhood cancer survivors in our study. So this slide here, I'll walk you through it a little bit. So here we were really interested in looking at that out-of-pocket cost threshold of 10% that we've described throughout our slides. So just to walk you through this, so if you look at the access down here at the bottom where you can see the out-of-pocket costs, we categorized this by asking individuals to report in the survey how much they were spending per year out of pocket on their medical expenses. And we were able to look at this in relationship to their household income to create this 10% category. So here you can see for individuals who report spending more than 10% of their income on out-of-pocket costs, so again, among the survivors, not surprisingly, almost 70% of them report problems paying medical bills in the past year. And when we looked at this among the group that reported lower out-of-pocket costs, so 10% of their income on out-of-pocket costs, this was much lower, less than 20%, so that's about 17%. And so this was really interesting to us, but not totally surprising that those spending more out-of-pocket were reporting a bigger medical bill burden. So we were really interested in looking at, what kind of services may be impacted because of this medical burden and financial burden. So in another set of analyses, we looked at some of the results from our survey around a question that asked about, in the past year, was there a time that you did any of the following, so avoided certain medical care because you were worried about the costs? So basically, this was a series of questions that asked about several different types of medical care. So did you put off or postpone preventive care, dental care, vision care, those types of things? We also asked people if they did not fill a prescription or took a smaller dose of a prescription. And then we also asked survivors about whether they had skipped a medical test, had a medical problem, and didn't go to the doctor. And so with this set of questions, we decided to summarize it to understand the number of missed medical care events. So walking you through this figure here, so you can see on the bottom row here, we categorized the number of missed care events into 0, 1 to 2, and 3 or more. And so looking at this, you can see that about 50% or more of survivors report skipping at least some sort of medical care in the past year because of costs. And so when we looked at the same measure in a regression model, so in a model that takes into account lots of different factors, we found that insurance, not surprisingly, is the biggest driver of missing medical care. So if someone's uninsured, they're more likely to report skipping care. This next slide shows a breakdown of our out-of-pocket cost variable by these different missed care opportunities that I was just describing on the earlier slide. So I'll walk you through this because I can see that this is a very busy slide. But here again, we categorize people into whether they were spending more than 10% of their income on out-of-pocket medical costs. And so the dark blue shows those that are spending more than 10%, and the green bars show those survivors who are spending less than 10%. And so I'll just highlight a few of the key results here without going through everything. But if you look at the top part of the figure, you can see 36% of those reporting spending more than 10% of out-of-pocket, or 10% of their income on out-of-pocket costs, reported taking a smaller dose or fewer pills than were recommended, compared to only 10% of those who are spending less out-of-pocket. Another one I will highlight is down here, kind of towards the bottom. We see that those spending more out-of-pocket are less likely to see a specialist if they need to, having had a medical problem. So 58% of them report having a medical problem but not going to a provider, compared to only 23% of those with lower out-of-pocket costs. And then again, we see that the survivors spending more out-of-pocket are more likely to skip medical tests as well as other preventative care services. So just to sort of summarize the results from these sets of slides, and then I'll go into some more broader implications. So we found that childhood cancer survivors do experience high financial burden, and that this is impacting their medical care utilization, and that they're reporting that, even within the past year, that they're reporting some of this medical cost burden in their care utilization. Additionally, worry about medical expenses does impact childhood cancer survivors' receipt of appropriate health care, and our findings do suggest that survivors' out-of-pocket burdens could lead to financial distress and really negatively impact their care and potentially their outcomes in the long term. And so just to provide some overall conclusions from Dr. Park and my work, along with our team, So we're finding that childhood cancer survivors, and particularly the uninsured survivors, do lack familiarity with the Affordable Care Act and other insurance protections that are out there. And that we found that many of the preferences around coverage do match the ACA provisions, such as not being able to be denied health insurance coverage because of pre-existing conditions, those types of things. And so this has really keyed up the next phase of our work to figure out what sort of education and assistance is needed to support survivors. And we believe this is particularly important, as many of you are aware, with changes in the Affordable Care Act that will likely be coming down with the new administration. I won't go through this in too much detail, but this slide just shows a little breakdown of the Affordable Care Act on the left, and then some of the potential changes around the American Health Care Act that, as we know, is still being discussed. And so I just want to highlight a few things that we found in our research and other folks have found in their research for things that are very important for individuals with pre-existing conditions, such as childhood cancer survivors. So unfortunately, there will likely be some changes in the Medicaid expansion, as well as who will be covered under Medicaid because of the way money is being provided to states. There will also be some differences in things such as premium subsidies and tax credits that may impact some of the lower income survivors that we see. We do think that there are some positive things that hopefully will still be in place under the AHCA, such as keeping dependent coverage, so people being able to stay on their parents' insurance through age 26, which we know from many of our studies survivors really appreciate, as well as others such as pre-existing conditions policy. What this means from a cost standpoint still isn't fully known, but there is some hopeful information still coming out on the AHCA around some of these things. Okay, so in our next step, Dr. Park and I would really like to expand our survey to really look at some of the changes and challenges in health insurance coverage, underinsurance, and familiarity with insurance as the ACA has been rolled out and during potential changes after some of these things change under the AHCA potentially. And our idea with this is to really understand the changing landscape of insurance for survivors and to develop a program focused on insurance navigation to really give survivors the assistance they need in obtaining and utilizing healthcare coverage, and also giving them some tools to manage their healthcare costs. So in this next study, our goals will be really to understand how health reform has affected the lives of survivors and to develop this survivor-focused program. So our study design will be really a three-part study where we'll first do an updated version of our survey to understand what's happened in the past 5 or so years since we originally did our assessment. Then we'll be working with a team of clinicians, social workers, survivors to develop a health insurance navigation program. And this will be actually delivered over the phone so survivors can obtain support and navigation around their insurance really from anywhere. And then we'll be working throughout the program to really refine it. And just to finish up, since I know we're almost out of time, to give you a little bit about context on patient navigation and cancer care, and why we think this is such an important strategy is patient navigation has really been deployed to try to reduce disparities in cancer, really around things such as cancer screening. But it's been increasingly moved into really helping support cancer survivors. And so as some of you may be aware from the Affordable Care Act, navigator services are mandated under the ACA as part of the health insurance exchanges, so the state exchanges that I'm sure you've heard about. But really these help people get enrolled in insurance, and they don't necessarily help people make decisions in the long term about their insurance and their care utilization. And so the goal of our program really will be to help patients and survivors be able to really navigate their insurance in the long term. And if we do have a few minutes at the end, if people have feedback or ideas around this navigation program, we'd love to hear more about it as well too. And just to sum up, I would like to acknowledge our team, including Ryan and Doug Fair, who helped to do these analyses looking at the cost questions. And then just to finish up, I also wanted to show a slide. This is a little busy, so I didn't go through it in detail, but this really shows the content that we're hoping to target with our navigation program as well too. And I'll move it on to the last slide then for George.
Great, thank you. Thank you, Dr. Kirchoff. I appreciate that, and Dr. Park. Was a great presentation. Some of it was very interesting because it was indicated that you had mentioned in one of the pieces about the American Health Care Act, and also the as comparison to the ACA, and of course Congress is still debating those things right now. And we may find that that has changed quite a bit. In fact, some of the new iterations of that are including you had a potentially keep of the essential health benefits, and that may actually still be problematic. So we'll see what happens.
Yeah, at the 11th hour, correct. But the provision to protect individuals with pre-existing conditions actually has been strongly upheld, and I think has been very, very popular and salient. So hopefully that will be secure, as that I think directly affects childhood survivors and vulnerable populations.
Absolutely, it's critical. It's very critical. Well, unfortunately, we're running out of time, but I do want to thank Drs. Kirchoff, Park, and Bona for their time today. This has been a great piece of work. Children's Cause has a great interest in this because it is a very topical issue. We think that this is incredibly important, and the work that you are doing right now adds to our body of knowledge and our ability to try to affect some of the changes we need to do on a policy level. I hope we've generated some questions, and I hope that some people in the audience will be submitting those to Children's Cause. You'll be able to watch this or pass this on from our website. Certainly, if you have any stories or incidents, anecdotes yourself about the battles you've had with financial issues or access issues, please include them in our survey and or submit them on our website. Again, I want to thank you, Drs. Kirchoff, Park, and Bona, for joining us today and sharing your insights. We'll be conducting these webinars on a regular basis and bringing you topics and speakers to help you inform and energize you in your advocacy efforts, as well as doing training sessions to be better advocates. So we hope you'll join us again. And until then, thank you, and have a nice evening and a good weekend. Thank you very much.
Thank you.
Thanks.
Thank you. Thank you.
All right, thanks.